presentation of some important new technology. We have some time for some questions, and there's a number in the chat room. I'll start by asking you, can you comment a little bit on how you envision the role of this valve that you just described versus both the transcatheter Melody valve and also maybe the Gore-Tex bicuspid valve that's been described and utilized by Jim Quintessenza?
Well, thanks, Jeff. I think to address the second question first, I think Jim's valve that he's been hand manufacturing, much like the valves made in Japan, is sort of the origination of this idea. I do think that for us congenital heart surgeons, a valve that's manufactured by industry to very specific standards using some of the same techniques and technology should clearly, in my mind, probably be a better valve. So that's the goal. Regarding the role of this valve versus percutaneous valves, I think one thing about this valve is that it is set up so that there are gold bands on the valve that can be seen radiographically, so that the valve is teed up for the placement of a percutaneous valve at the appropriate point when that time would come.
Well, thanks. And I thought it was important to acknowledge the work that Jim Q's done in this area that in many ways laid the groundwork for some of this. Elizabeth Stephen states, exciting, what are the next steps? More sizes, making distal grafts more closely match material properties of the PAs. So she kind of wants you to comment on where this technology is going to go next.
Well, our next step is to have multi-center trials with probably around 10 to 15 centers. The company is going to be manufacturing 4 different sizes of valves, 12, 16, 20, and 24. So we will be able to apply it to a broader range of patients. And hopefully that initiative will start in late 2021 or early 2022.
Okay, and then our program chair asks, this is Luca, would you use these in patients with distal disease and high pulmonary artery pressure?
I believe that I would. So far, we have had some patients with those same issues, and these valves appear to be very strong. A further goal at some point is to be able to use these valves on the left side. So I think much like Dr. Kalfa's presentations, the makeup of the valve itself can be changed, altered to increase the strength and have different potential uses for the valve. But I think it's going to be good even for patients with high PA pressures.
So sticking with that theme, Dr. Tweddle asks, can you tell us something about the material used for the valve cusps?
Well, it's a proprietary material. It is a form of PTFE, but it's, again, manufactured by industry, and again, it's a proprietary material.
Okay, and then Carlos Miri states, what was the mechanism of the PI seen at 6 months?
Well, one of the interesting things about this valve is that it's actually part of the design is to have small washing jets, which help prevent thrombus formation. So each of the commissures is purposely not completely made to close, so that there is a little turbulent washing effect. And that is the mechanism that is the mild pulmonary valve insufficiency. So it's actually something that's built into the valve design itself.
Well, thanks, Carl. That answered the question of several people on the panel, including also Dr. DeCampley. I'll ask one final question, and then we'll move on to the next section. And this comes from Jim Jaggers. Do you think that the rigid ring has been helpful or protective for valve function?
I think the rigid ring is helpful. I think it helps maintain the uniformity of the valve, and any distortion in the valve cusps can lead to pulmonary valve insufficiency, which then can become a self-perpetuating problem. So I think that the rigid ring is actually quite important.
All right, I'll throw out one more because we still have a little time. Tom Carl states the Yamagishi valve has the best long-term outcome of any known conduit. Will it be available in the US? Do you have any information about that?
I don't have information about that, but I think the idea of this valve is to replicate what Dr. Yamagishi has done and provide the same type of long-term durability.
Well, thank you, Carl, for sharing that information and answering a rapid fire of questions like only a past CHSS president could do. This was a wonderful presentation.
That's because I have the new CHSS tie on. So everyone go to the website when it's available and donate to the Kirkland Ashburn Fellowship.
Yeah, the tie gives you superpowers to answer questions rapidly. So thank you very much. We're finishing right on time. This session ends at 11:17, and it is now 11:17. I'd like to thank my co-moderator and good friend Bogdan Marashevsky, and also thank all of the presenters and discussants for allowing us to finish on time. And we will end this session and move on to the next session. Thank you, everybody.
Thank you.
Great, thanks, Jeff and Bogdan, and to the presenters for just some excellent talks. I'd like now to ask our CHSS president to turn on his webcam and unmute his microphone. Joe is our Section 6 moderator, and this session is entitled Pediatric Cardiac Surgery in the COVID Pandemic.
Thank you, Dr. Maricella. We have 4 presentations in this special session today. We'll have the Q&A at the end of the 4 presentations, but you can submit your questions anytime along the way. Luca, you and I can tag team the questions. Anyway, Dr. Jim St. Louis from Children's Mercy Hospital of Kansas City will present the first of multi-institutional abstract for the session entitled, quote, Initial Impact of COVID-19 on Congenital Heart Surgery Programs in the United States and Canada. Jim, thanks for your hard work on this project. We're looking forward to hear it. Dr. St. Louis.
Hello, my name is Dr. James St. Louis. I'm the current Chief of Pediatric Congenital Heart Surgery at the Children's Hospital of Georgia. I would like to thank the leadership of both the CHSS and ECHSA for the privilege of presenting this joint study and wish to convey our deepest sympathy to all members of our society who have been affected by this pandemic. I have no disclosures. The information I will present is the result of an unprecedented collaboration by 3 of the major congenital heart surgeons societies across the globe: the European Congenital Heart Surgeons Association, the Congenital Heart Surgeons Society, and the World Society for Pediatric and Congenital Heart Surgery. Members of these and other studies banded together to create the COVID-19 International Congenital Heart Surgeons Task Force. Coronavirus disease 2019, or COVID-19, is caused by the virus SARS-CoV-2. This is a novel virus that causes an initial respiratory illness similar to other coronaviruses. The specific aims of our study was to assess the early impact of the COVID-19 pandemic on hospitals and congenital heart programs in the United States and Canada. This was a sub-analysis of an effort of the task force to evaluate the impact of COVID-19 across the globe. As of October 2nd, 2020, over 30 million people have been affected with the COVID virus, 7 million in the United States alone. This map represents a distribution of the COVID-infected individuals across the globe. Unfortunately, over 1 million people have succumbed, with greater than 200,000 in the United States. The COVID-19 International Task Force for Congenital Heart, Task Force for Surgery, is a combination of multiple societies across the globe. The societies came together in a number of Zoom calls to construct a survey of 50 questions broken down to country, institution, and congenital heart surgery program. This was distributed via leadership within the society. The survey was made accessible from March 27th to May 4th of 2020. 49 responses were taken from the United States and Canadian centers, 53 representing individual institutions from 24 states. This represented approximately 43% of congenital heart programs in the U.S. This map represents a distribution of responders. The first reported case within the survey was on February 12, 2020 from Washington State. The last reported was in Georgia on March 30th, 2020. At the time of the survey, all schools and public services were closed. The majority reported stay-at-home orders or mandates were in place. At the conclusion of the survey, 100% of the closures remained in place. The majority of respondents worked at either standalone pediatric hospitals or hospitals associated with an adult hospital. There were no adult hospitals reported. All hospitals were either designated as COVID-19 referral centers or treated their own patients. No hospitals transferred patients to another hospital. When asked about space allocation within the hospital, the vast majority reported yes, this occurred, and those occurred within both the ICU and the wards. When he looked at institutional measures enacted, the majority of elective operations, admissions, and outpatient clinics were postponed. Remarkably, shortages in blood, ICU beds, and ventilators were not significantly reported at the time. The impact on elective operations for congenital heart disease was significant, with the majority of centers reporting elective cases or the majority of elective cases postponed. 100% of all emergent and urgent surgical cases for congenital heart disease were undertaken, and the vast majority of programs still had a neonatal congenital heart surgical program. Resources from within the heart center were diverted, but this was not a majority. And when they were, it often represented the operating room availability. Interesting, for overall programs, the majority of responders reported quarantine of hospital personnel, and a large portion had positive hospital staff for COVID-19. When asked recovering or had you recovered, the majority of individuals said we have not recovered or the recovery was gradual. In summary, at the conclusion of the survey on March 30th, 2020, initial social restrictions and mandates remained in place. All centers had not resumed operations for the respective congenital heart programs, with the majority elective cases being postponed. Emergent and neonatal operations were still performed. All centers cared for patients with COVID-19, regardless of the hospital designation. Hospital resources were not significantly limited at the time of the survey, and a significant number of hospital personnel tested positive for the COVID-19. Few of our specialists were diverted outside the institution. This study creates the foundation where our practice existed at the time of the pandemic's initiation. The strength of this project is made up and supported by all major congenital heart surgical programs across the globe. This survey will be followed up by a follow-up survey that is currently being distributed. Thank you.
Well, thank you, Jim. Okay, to present the impact of COVID-19 pandemic on pediatric and congenital heart surgery programs across Europe, we will now have Dr. Protopoulos from Athens review the European experience. Dr. Protopoulos.
Good morning. First of all, I would like to thank the Society for the opportunity to present our work. Aim of our study is to identify the early impact of COVID-19 pandemic on pediatric and congenital heart surgery programs across Europe. Professor James and Lewis presented the North American data, and now I will present the Europeans. As you already hear, this study is a teamwork project from collaboration of European Congenital Heart Surgeons Association, of Congenital Heart Surgeons Society, of World Society, of Japanese, Korean, and Indian Pediatric Cardiology and Cardiac Surgery Societies. The survey was created through a series of conference calls and had three parts. The first part had questions about country status, the second one about hospital, and the third about congenital heart surgery program. The survey distributed through societies memberships, and all the responses collected at the ECHSA congenital database from 27th of March till 4th of May. As you see in this slide, this time frame was capturing the peak of the first wave of the pandemic in Europe. In total, we have 176 hospitals from 52 countries participated around the world, and in Europe specific, we had 46 hospitals from 18 countries. Public health-driven societal restrictions intended to inhibit the spread of the COVID-19 infection and were imposed to almost all Europe. Schools and public services were closed, and in 90% of responses, citizens were ordered to remain at home. At the same time, hospitals discontinued elective operations and applied different policy regarding COVID-19 patients. In almost half of the hospitals, patients accepted and treated as needed, when in one quarter, transferred to another hospital designated as referral hospital for COVID-19 patients. The large majority of the hospitals set dedicated spaces for treating COVID-19 patients in wards and in ICU, and suspended elective admissions and outpatient clinics. By the time that survey responses were submitted, no shortages were experienced in blood supply or in ventilators in most of the hospitals, although Europe was in the peak of the first wave. In one quarter of our hospitals, shortage of ICU spaces was a major problem. ECMO support was available in almost all of hospitals that responded to our survey, but it used only to support adult patients with COVID-19 infection. In this slide, we can see the impact of COVID-19 pandemic in congenital heart surgery programs. Half of them reported that the approximate reduction of surgical volume was more than 50%. Diversion of doctors, nurses, and other staff from congenital programs to other departments was reported in 29% of responses, and in 2/3 of programs, 10 to 20% of staff was quarantined due to suspected or due to tested positive for COVID-19. Very interesting is that the 3 out of 4 hospitals reported that the loss of personnel did not affect the function of their clinical services. In the first pie chart, we can see that at the closure of the response period, only 3% of the programs had resumed normal services, and in the 69%, the restricted situation remained unchanged. The estimated time interval required to recover was 1 to 2 months in 32% of the programs and 2 to 4 months in 41%. Now, unfortunately, we don't have enough data about congenital heart disease patients with COVID-19 infection. 169 patients cared from cardiology departments due to COVID-19 infection. Half of them were treated in home isolation, and the rest hospitalized in wards or in ICUs. 4 pediatric patients with COVID-19 underwent an urgent operation, but the outcome was not affected. On the contrary, 5 patients were turned positive after the operation, and the surgical outcome was adversely affected in 3 of them. The limited number of patients, of course, cannot lead us to safe conclusions. The nature of a survey and the fact that at the time of survey various countries were experiencing different periods of the curve are the major limitations of our survey. In conclusion, we can say that public services, including schools, were closed in almost all Europe. The majority of hospitals suspended elective operations, including congenital procedures. Most programs refers minimal loss of resources. Majority of programs lost personnel due to COVID-19 pandemic, but only 1 quarter believes that this reduction affected their services. ECMO was not used for pediatric patients during survey window. The extremely small number of reported congenital heart disease patients with COVID-19 infection who underwent operation is a fact. A follow-up survey is being distributed now. Thank you very much and stay safe.
Well, thank you very much for that stimulating presentation. It's very interesting to see the similarities and differences between North America and Europe. So during the planning phase of this meeting, the program committee decided that we would invite 2 cardiac surgeons to provide a personal perspective on the initial most deadly months of this global pandemic. And the 2 surgeons that we chose were really viewed to be on the front lines in their respective centers that went on to be epicenters, one from New York City and one from Milan. So the first presenter will be our dear friend and colleague from the CHSS, Dr. Emil Basha, who will provide his personal reflection on COVID-19 in New York City. Emil.
Hello, my name is Emil Basha. I was asked to give a talk on personal reflections on the COVID-19 pandemic in and around New York City in the spring of 2020. I think everybody is well aware of what happened in New York City in March of 2020. On March 1st, we had one COVID case in the entire state. By April 1st, a month later, we had about 83,000 cases with 2,500 dead people, and the number of patients that were getting sick daily was absolutely astonishing and terrifying at the same time. The hospital I practice in has a pediatric and an adult campuses. Altogether, there are about 3,000 beds, and the number of COVID patients peaked around March 11th at around 2,500 patients, which is an incredible number. So more than 2/3 of the patients were COVID positive in the hospital at that time. It was really an incredible challenge, which everybody took head on. On the pediatric side, there are two main campuses, the Morgan Stanley Children's Hospital being the main one. Initially, the PICUs and the pediatric CICUs were protected, but there were just so many COVID positive patients that, and because of our, so to speak, ECMO expertise, adult patients were sent to our ICUs and cared for by the pediatric staff. On the pediatric cardiac side, we were down to one OR as opposed to 2 or 3 on a given day, but we're working 7 days a week to make up for the one OR we had. Now, performing pediatric cardiac cases during a pandemic or during any crisis is different from usual. The pediatric cardiac staff is anxious. There's a general lack of focus. You can tell people are distracted. And the fact is, you are doing a case and you're trying to protect that patient. And we all know what happens with lack of focus. Mistakes are made and bad outcomes occur. So your role as a surgeon, as the leader of the team, is to focus everybody and make sure they understand that really, even though everybody has a lot of worries and is thinking about other things, possibly because it's such unusual times, that in fact, at the moment, they have to focus on the patient, and that we're all in this together to get the patient safely through the operation. There was no teaching going on, and really every case was extensively discussed. Now, during this chaotic time, a lot of people were reaching out and asking how we were doing, and so I decided to reply all in a lengthy email where I described what was going on. For example, talking about the lack of protective equipment, which was really galling because as a surgeon to not have a face mask is really incredible, especially that this could happen in one of the most, if not the most advanced country in the world. But I also talked about the difficulties we had with triaging and the ethical and dilemmas that we were faced with making these decisions. There are no real guidelines. We published some later on, but initially there were no guidelines. And so what do you do I gave some examples. What do you do with an infant who has a small shunt, whose saturations are not very good? Do you delay them? Do you not? What do you do with a child with severe valvular problems or anomalous coronary with syncope? How long can you delay them? And what do you tell these parents about the risk that the child faces? So those were difficult decisions that had to be made on a daily basis, and it was kind of exhausting, to be honest with you, to have to make these decisions and to have to stand by them, especially if you told given patients, no, we cannot do this operation on your child because there are no resources and the hospital is full with patients who have other problems. Now, this email was leaked to social media and ended up with CNN, which used it as a summary and documentation for a lot of their articles, which was fine. That wasn't really the intention of it, but I ended up speaking with some of the reporters, and as long as they were reporting correct things. I did not have a problem with that. Certainly did learn a lot of lessons from this crisis, which is not over yet. For sure, lesson number one is intense communication. You have to be very much communicating with your team and your staff at least on a daily basis, if not twice a day during these extreme times. This is very, very important. I certainly neglected and or thought this wasn't as important, but I can assure you it is crucial to do that. Now, the atmosphere during those times reminded me of my time growing up in Lebanon. Some of you may know that I grew up during the civil war in Lebanon, and this was a very similar atmosphere where there's a lot of tenseness, a lot of anxiety around you. And the most difficult thing to deal with is actually the unknown, the fact that you don't really know what's going to happen to you, to your loved one, next week, next month. Where is the world going? That is actually much more difficult than the actual hardship, than the actual, danger or hunger or whatever you're having to deal with. And so at the time in New York, and as in other places, Wuhan and other places, we did not know whether this pandemic was going to kill us all or going to subside or what was going to happen. And that is actually something that is difficult to deal with. On a personal level, several colleagues, many colleagues actually became ill and infected. More than half our resident and fellow staff in cardiothoracic surgery became infected with COVID because they were on the front lines dealing with patients, putting in lines, intubating, doing tracheostomies. 3 out of 8 adult cardiac surgeons became ill because they were also in the ICU since there was not much adult cardiac surgery going on. Tom Cato, who's a good friend of mine and a world-renowned pediatric liver surgeon, became infected during an operation in early March. He almost died, came very, very close to dying, was 3 months in the hospital, was intubated, was on ECMO, which put a chill through everybody's spines. To hear that Tom was on ECMO, and it was incredible, but he eventually survived, and we're very grateful for that. And he's actually back at work. Unfortunately, not a good outcome for some other colleagues. This is a colleague from the emergency room, doctor whose office is very close to mine, who committed suicide, and it's clearly because she could not deal anymore with the onslaught of COVID patients coming in and day out, and she just thought that this was absolutely not something she could deal with. Very unfortunately, did not reach out for help. So that was a very sad ending. What is going to happen to all of us? Obviously, I don't know. I know right now this is what's going on in New York, empty streets where normally hustle and bustle will be going on. But at the same time, as a student of history, I can tell you that Florence in the Middle Ages, when the plague was raging, Florence lost about half its inhabitants. When the plague was over, these inhabitants moved back in and actually launched the Renaissance, which, as you know, is one of the most fertile periods in human history. So that specific energy that survivors have, I do believe, will come into play when this COVID problem is over. Well, to finish, I would say that to do what we do, you have to be an optimist. There's no other way to do it. And I do believe things will work out. When this is over, society will have changed, of course, but basic values of human behaviors, ethics, and norms will survive and maybe even strengthen. Thank you very much for your attention.
Well, that was incredible. And I think I just wrote down a few notes of the words that stuck in my mind listening to Dr. Basha. Terrifying, incredible challenge, anxious, lack of focus, and being distracted, resulting in mistakes. The ethics of triage, difficult decision making, lack of resources, warlike atmosphere, the fear of the unknown and uncertainty and our future, and the importance of being an optimist. Emil, that was really, really amazing. So we're going to shift the personal reflection now to Europe, and we're going to have Dr. Alessandro Giamberti talk about his experience now in Milan, one of the other epicenters. Dr. Giamberti.
Good morning. First of all, I would like to thank Dr. Richella to invite me at this important meeting. Well, I have no disclosure to declare, and I try to focalize my personal reflection around three questions. What have we done? What could we do better? And what have we learned? The majority of the information that I will show you come from two papers, one already published regarding how we reorganize our system in Lombardy, our region around Milan, and a second paper that will be very soon published in the European Journal of Cardiothoracic Surgery, that is a national survey about the impact of the virus in the Italian congenital cardiac surgery system. As you probably know, starting from February 2020, Italy became one of the most affected countries by the virus, forcing the Italian government to quickly introduce a complete lockdown with emergency quarantine and isolation measure. At that time, for 8 weeks, the priority was to treat and manage a patient with COVID-19. And obviously, all the elective health services have been stopped or postponed, and the majority of the hospitals transformed in COVID-19 hospitals, and a lot of health providers relocated in the treatment of these patients. As a congenital cardiac surgery system, our duty at that time was to guarantee adequate health services to urgent congenital heart disease patients from fetal to adults, to guarantee safety of the healthcare providers, the safety of the patient and the family of the patient, and to have a cohesive approach with innovative and collaborative strategies. The first important thing that we learned was that the virus had in Italy at that time a completely dishomogeneous geographical spread, with a higher concentration in the north of Italy, and in the north a higher concentration in Lombardy, our region, with close to 35-38% of infected people of all the country. And obviously, the most important transformation of our system was in Lombardy, where the local administration introduced the hub and spoke model. In Lombardy, we have 3 centers of pediatric cardiac surgery. 2 of them have been completely closed, Niguarda Hospital and Bergamo Hospital, and the only one that works at that time was our hospital, Policlinico San Donato. So all the emergency cases from the region could be operated just in our center, give the opportunity to the colleagues of the cardiac surgeons from Bergamo to Milano Niguarda to come to our hospital, to operate patients and to work together. In Italy, we had a 57 reduction of ICU beds, usually dedicated to congenital patients, and we have 15 centers doing pediatric cardiac surgery, and only 4 of them remain completely COVID-19 free. Most hospitals had a reduction of healthcare providers usually dedicated to congenital patients. The majority were the anesthesiologists that has been relocated to the treatment of COVID-19 patients, followed by nurses, especially ICU nurses and perfusionists. Only 7% of the pediatric cardiac surgeons have been relocated to other units. And these are the patients that we have operated in Italy at that time. In the 8 weeks of complete lockdown, we had a reduction of 52% of the activity related to the same period of 2019. The majority of the patients were urgent and emergency patients. And we had a very good result because we lost just 1 patient on 263 patients that we operated. And no one of these patients were positive, COVID-19 positive before surgery, and only 3 of them became infected after surgery, but with a complete recovery in all 3 patients. And this is what's happened about the healthcare staff. We have 12 doctors that became positive during the period, and 29 nurses. And the majority, once again, of the doctors and the nurses that became infected were in the north of Italy. So what we have learned and what could we do better? The COVID-19 pandemic had a different impact in accordance to the different geographical spread of the virus. The activity of a cardiac surgery for congenital heart disease in Italy decreased of 52% during the lockdown. And the results of the patient operated were very good. And I think that the congenital cardiac surgery system responded very well. We have seen a great spirit of collaboration between the center, between the cardiac surgeons. But honestly, the complete lockdown was just 8 weeks, so a short period. We don't know what could happen if it was longer. And probably to do better, we needed to have a more centralization of the congenital heart disease patient in really few centers, completely COVID-19 free. And let me conclude with a hope, with a reflection of hope as Italian. All the great historical revolutions are characterized by profound crises that have pushed the start again with greater strength, achieving even greater results. During the crisis in the Middle Age, characterized by the Black Plague and famine, Italy saw its population halve in a few years. The nation recovered with difficulty and a profound transformation of the society, which ultimately led to a rebirth, also known as Renaissance. Thank you very much for the attention.
Thank you, Dr. Gambergi. And in the spirit of just a few words that I've heard, hub and spoke and the importance of centralization, the spirit of collaboration, lockdown, and finally hope. So these were 2, I think, really wonderful presentations, and we're glad that you stayed safe and sound during these most difficult times. We've learned from your experiences, and these kinds of lessons learned from in each location, I think, will be helpful moving forward in the event of a rebound or a spike. And thank you. So with that, I think, why don't we take some questions? Luca, do you see a few on deck there?
Yeah, so the questions are kind of coming in. I just wanted to add a couple of comments. I think, in hearing these very inspirational, very, factual talks about a global pandemic, I was struck by thinking about how we were, 4 or 5 months ago in terms of the pediatric cardiac surgical community. I think, even though, this was, something coming up and hitting us hard, there was this, unknown, as Emil said, that really was, plaguing our institutions, our daily lives, and our work. And I think, most centers, aside from the ones that were in the epicenter, like Milan and New York, really kind of experienced, probably regardless of the size, or their, a very similar kind of approach. They rationed the resources that had. We established, guidelines, at a time in which really things were uncharted waters that we were navigating. So, I was kind of interested by Jim St. Louis' slides, and there was one in particular that talked about, was a question about whether, you experienced recovery, whether you felt you had recovered. And Jim, your survey concluded on March 30th, which was kind of at the height of this initial experience. So, I wonder what would be that same question, given the lessons that we learned, the answer to that question, given the lessons that we learned, how we have sort of learned to, rationalize our resources and follow certain guidelines that are tailored to our institution, to our different institutions, how this would actually be answered, perhaps now or maybe in a few months from now. So, I hope sincerely that this year we're going to have a follow-up session at the next CHSS meeting that's going to be called the Renaissance session, because we've hopefully, just gone over this and came through with flying colors. So Jim, one of the questions that came through from David Overman, he just wanted to know what are the metrics that you're going to include in a follow-up survey to the one that you've just presented?
That's a great question. Thanks very much. The survey has actually been released again. CHS members, the follow-up survey, CHS members should receive the survey link pretty quickly right after this meeting. It was released to the World Society as well as the ECHSA Society, as well as several other major societies. But it was very focused this time on congenital heart programs. Our initial survey had a near split sections on country, how it's affect, region, how it affect, and how programs affect. But we focused on those questions and expanded those questions that we constructed for programs themselves. So questions like you said, how were resources diverted? What resources were diverted? When do you anticipate or are you anticipating, escalation of elective cases, which we all are doing now? So I think the follow-up survey is out. It will address the exact points that you made. And I'm really looking forward. And I want to just say one thing, is that this for me has been an incredible experience, both to listen to Emil, but also to listen to all our colleagues across the globe that came together to help with this project. And we did this through a number of Zoom calls, and it was just impressive to hear and scary to hear individuals from Italy and Vladimir and individuals from other parts of Europe and China and Korea talk about us one-to-one during these sessions. So I think it will reflect more impactful on the next survey that will hopefully get it published by the end of the year.
One question from Petros Alagastopoulos. How do we move from the acute change management to more chronic management with resilience for a longer period of time? Alessandro, what do you think?
Well, no. As I said, it was a short period, the complete lockdown, so it was not so complex to manage the situation. I think that we have to learn that we should collaborate more between the centers, and this is because now in Italy, as you know, probably know, we are facing a second wave, and we are starting to see the same numbers of March or February. So really, I don't know what we will do, what we have to do. We have to follow the instruction of the local administration, but we have to take into consideration what's happened in the past. So I hope that, for example, in Lombardy, we will continue to collaborate strictly between the centers. I think it was a great experience because the surgeons from the other two centers moved to my centers. We collaborate, we operate, we work together, and that is not simple. Theoretically it's simple, but practically it's not. And different protocols, different theaters, nurses approach, ICU, but really went very well. And I think that we have to take into consideration this for the future.
Yeah, I think, Alessandro, you're right in that, never miss an opportunity in a crisis. And, the opportunity that we all had here was to come together and not just, with a phone call, but actually working together in the trenches. I completely agree with you. There's not that many other questions. One comment that I have here from Emil actually is wear your mask and listen to the scientists. And this, of course, is a very politically charged, comment in this day and age in our country. But, I think this is true in the entire world. So I wanted to just thank you all for just not just, being on the Zoom call and, being a part of this program, but really for all that you've done. All of us as surgeons, are grateful to, to our leadership, our community for what they do every day and, how we protect our patients, most importantly.
Luca, one more comment from me. First, this was just an amazing session, and we anticipated it would be given the people that were involved. But just a couple closing comments. First, I know the scientific papers will result in a publication, but I would strongly encourage Emil and Alessandro to try to put down in words this presentation that could be published in the World Journal, because it will mean a lot to all of your friends and colleagues around the world. And secondly, to Luca's point about the world falling down around us and the spirit of collaboration. And it's kind of ironic that the CHSS ECHSA joint meeting happens to be this year, the year that where all of this sort of occurred. And it's in many ways a symbol of how we are truly, I think, joined together, and how we behave when the world is falling apart around us. And we came together in a major way right now. And I think this is one specialty, I think, that really sets an example for so many other specialties in the healthcare industry. And I think we should all feel really proud and good about that. So thank you to everyone. This was just an amazing session from my standpoint.
Thank you. Thank you.
So thanks, everyone. This was really amazing. Let me just move to the next item on the agenda. We have Professor Jose Fregada from Lisbon, who will actually introduce formally Dr. George Saris for the ECHSA presidential address. Jose?
President of CHSS, Dr. Joe Diorani, President of ECHSA, Dr. George Saris, dear members of CHSS and members of ECHSA, colleagues, ladies and gentlemen. It is a great pleasure to introduce George Saris, the President of ECHSA, at the CHSS ECHSA meeting, where two sister associations meet once again to reinforce legacies of science, respect and friendship across the Atlantic. The times of uncertainty and challenge we live now force us to connect virtually as a way to staying together. An example on how right visions and focused missions prevail over any adverse momentary circumstances. The shared vision and mission of my two beloved associations, as I'm privileged myself for being a member of both. Introducing George is an honor and a challenge. As I must disclose, George is an old friend of mine. I will start by George's roots and family to describe the man that stays behind the surgeon, then to profile the surgical leader that stands before all of us. George was born in Greece in 1956, being the son of two Carpathians, and Carpathos being an island in the beautiful Aegean Sea. His father was a doctor that unfortunately passed away when George was only 10, leaving her mother to raise their 4 children. Initially educated in Athens, he would leave to study in Harvard, from where he graduated in medicine. He attended the MIT doctoral program in health science and technology to receive later his PhD degree in medicine from the University of Athens. George's lonely days in Boston would be enlightened by Anna, a love for their entire lives. After concluding the internship in Boston, they would marry, still a running enterprise. And here we can see Anna telling George since their very beginning that the final word for the rest of their lives would be his own word, George's word. Yes, darling, you are absolutely right. They were blessed by 3 kids. Here Anna and George with their kids at their daughter's graduation. And here one of the boys in the army, not hunting ducks, but mostly likely watching out for the Turks. During his training in the US, George stayed at top places with the cream of cream, and that was the kickoff of a brilliant career. I always teach my residents that they will never excel at surgery without first being good persons. British poem named If by Rudyard Kipling provides the best ever description of a man. Poem celebrates lauding attributes of a man such as patience, courage, pragmatic thinking, capability, independence, and leadership. These attributes are all to be recognized in George's character and sent behind the surgeon that is, above all, an excellent person. I will now describe George as an academic surgeon. My former mentor, Mark Laval, defined academic surgeons as shining in clinical practice, research, education, administration, and leadership. Well, George is a talented congenital heart surgeon with excellent results. For a few of us working in deprived setups, climbing the tree of success takes as much sweat as it does for technical expertise. George, you succeeded where many of us would just give up. Here are his results and professional affiliations. George debuted medical research soon. Here we can see him in Greg's Miller research lab, and these remarkable contributions in our field, namely for ECHSA multicentric studies. His H-index and citation tolls are quite impressive. And innovative artificial intelligence methods for outcome analysis constitute his most recent interest, soon to be published. Teaching is another of George's interests. Here in Athens, with me and other colleagues at a hands-on course on surgery for transposition. Well, George is a good manager, from chief of department in Athens to secretary and member of ECHSA's executive committee, and now as ECHSA's president. Here during our busy executive committee meetings, working hard with Charles Keebles, our treasurer, and myself, still as president. George, I do miss those meetings a lot, and not only for the beer. Well, leadership is a value in greatest need presently. George Saris is a leader. He is a leader for his character and personality that I described along with Kipling's poem. But leadership nourishes itself on a blend of profiles: the artist, the craftsman, and the technocrat. George has the vision and creativity of the artist, possesses the knowledge and the realism of the craftsman, and when needed, vests the organized pragmatism of a technocrat. We all know that the heroism of leadership that many of us saw in our mentors as a common denominator, the fact that all of them, despite their charisma of artists, the candor and the technical brilliance of their craftsmanship, were exceptional human beings. Now, George, networking with a lot of friends, I think in Greece, now in Lisbon, while we were sailing, in the States, in Santorini, in Cascais, when I stepped down for president with many of our friends. And ladies and gentlemen, it is my honor to introduce our president, a surgical leader, but first and above all, an exceptional human being, George Saris. Thank you.
Dear colleagues, first, I would like to thank José Fragata for his most kind, generous, and favorably exaggerated introduction. José's leadership of ECHSA as the immediate past president has been landmark. Succeeding him as president of ECHSA has been the greatest honor of my professional life, and it remains a daunting task to even attempt to match his contributions to our association. In thinking about my presentation today, I have tried to look towards the future, not just of ECHSA, but of our subspecialty as a whole. I was stimulated by my experience of close collaboration with the artificial intelligence team of Professor Bertsimas at MIT during this entire past year, working to use machine learning, analyzing congenital heart surgery data. Thus, I decided to attempt to provide you with an overview of the fantastic opportunities and challenges provided to our specialty by the explosive progress of artificial intelligence. Of course, I wish to emphasize that I am by no means an expert on AI. Therefore, this presentation provides only the perspective of a clinical pediatric cardiac surgeon wondering if and how the impressive achievements and capabilities of AI could be harnessed for the benefit of our patients. In a paper called Medicine and the Computer, published in the New England Journal of Medicine some 50 years ago, Dr. Schwartz predicted that computing science will probably exert its major effects by augmenting and, in some cases, largely replacing the intellectual functions of the physician. As I will be showing you, this prediction has been proven largely correct, and in fact, the impact of artificial intelligence in medicine is even bolder. Increasingly, this dream is becoming to create a virtual global team of medical experts holding the ever-expanding accumulated wisdom of the decisions of millions of physicians regarding the medical issues and resulting outcomes of billions of patients. This virtual global artificial intelligence team will then be able to support the decision of every physician with real-time personalized advice on the diagnosis, management, and actual therapy of each patient. Before we consider whether such far-reaching promise is conceivably possible, some definitions are in order. Artificial intelligence is defined by Encyclopedia Britannica as the ability of a digital computer or a computer-controlled robot to perform tasks commonly associated with intelligent beings. This term was coined by John McCarthy in preparation for a Dartmouth summer research project back in 1965. And he stated that the study was to proceed on the basis that every aspect of learning or any other feature of intelligence can in principle be so precisely described that a machine can be made to simulate it. Pivotal in all these achievements has been the development of what has become known as machine learning, which is the application of AI systems to learn and improve from experience without being explicitly programmed to do particular tasks. Humans can learn to make general complex associations from small amounts of data. For example, a toddler learning to recognize a cat, whereas machines require many more examples and do not have common sense. They do not have what Michael Polanyi described as tacit or implicit understanding. Yet, although machines need massive amounts of data to learn from, their ability to absorb such data is practically limitless, and they do not tire. Of course, there are too many types of machine learning for a non-expert to understand and describe, but it is useful to distinguish between two general categories. In the supervised models, data sets are prepared and labeled by humans according to predefined categories, and the relevant algorithms are designed to orient only to categories and concepts pre-specified by us. In unsupervised models, pattern recognition is allowed to develop freely within the data, with algorithms learning without human-provided guidance. Looking at AI history, it is interesting that the subject of whether machines can be made to think has been considered in the 17th century by the French philosopher René Descartes in his 1637 book Discourse, a book famous for the quote, "Cogito ergo sum," I think, therefore I am. Descartes seems to have predicted that some machines could be made able to perform tasks as well as, or even better than humans, but he felt they could neither be made to talk nor to perform tasks based on understanding. Obviously, he was wrong on the first prediction, machines talking, and his second is being seriously challenged. Of the many exciting milestones of AI, too numerous to describe in this talk, I will mention just a few. The field may be said to have its foundations on a famous paper on computable numbers by the British mathematician Alan Turing back in 1936. Other milestones: in 1964 at MIT, Joseph Weizenbaum created the first chatbot called ELISA, which could fool users into believing that they were conversing with a human rather than with a computer. By 1997, IBM's Deep Blue computer defeated the chess world champion Garry Kasparov, stunning the world. In the next decade, progress was even more rapid. In 2004, the first self-driving vehicle competition was launched in the Mojave Desert. This is the Carnegie Mellon team. In 2011, IBM Watson computer defeated the then famous Jeopardy champions. In 2012, the famous paper on successful image recognition using ImageNet data was published, and within 3 years only, it was demonstrated that machines could recognize images better than humans. And in 2018, self-driving cars appeared in the streets. These achievements of AI, boosted by the availability of huge amounts of data, are staggering. So much so that Klaus Schwab, the founder and executive chairman of the World Economic Forum, introduced the term Fourth Industrial Revolution of AI as the theme of the 2016 forum held in Davos. This fourth industrial revolution of AI was described to follow the sequence of the first involving steam machines, the second involving electricity and the telegraph, and the third, that of automated production, electronics, and computers. But has medicine in general profited from this fourth industrial revolution, as predicted in the 1970 New England Journal of Medicine paper? The answer is clearly affirmative. Back in the 70s, computers in medicine involved only programming specific rules. Today, AI models have evolved to learn from examples provided as inputs, so-called features, and outputs called labels. The machines learn how to map features to labels and can perform this task with new previously unseen inputs, finding statistical patterns over millions of examples of features and labels. There are many achievements of AI in medicine. Most notably, they involve image and other pattern recognition in specialized applications. Machines can interpret medical images such as chest X-rays, CT scans, in fact, recently looking for signs of COVID-19 infection, or mammograms. They can read pathology slides of biopsy specimen, diagnose eye conditions based on retinal images, diagnose skin cancer based on photos of skin lesions, and they can even diagnose syndromic phenotypes based on facial photographs. There are other applications of AI in medicine in the field of genomics, where systems analyze huge data sets of DNA data to identify disease-related genes, aiming to achieve precision, personalized medical diagnosis and therapy. Now, all these achievements described can be thought of as applications of so-called narrow AI, as opposed to the more general and even more ambitious applications envisioned by Eric Topol in his book, Deep Medicine. This far-reaching vision of deep medicine involves eventually digitizing all relevant patient data, from anatomy to genetics, a process he described as deep phenotyping. This data set would then permit AI algorithms to provide full diagnostic and therapeutic assistance to the physician. And it is this strategic direction that was taken by IBM's Watson Health Division, aiming to provide decision support for physicians via analysis of massive data sets. IBM invested $1 billion in 2014 in its Watson unit and spent another $4 billion a couple of years later acquiring several health data companies. Nevertheless, successes in this mega project have been rather limited. Of many projects, ranging from management of diabetes to drug development, only the Watson for Genomics tool for cancer has reached maturity. Clearly, AI still faces major challenges in achieving tasks
which physicians can still do better. But let's take a look at tangible, practically useful AI-based cardiovascular applications. Again, those involving image analysis are most prominent. For example, the risk of ischemic events may be predicted from automated analysis of CT coronary angiograms, or the Ultromix stress echo analysis system can help diagnose myocardial ischemia by automatic detection of LV wall motion abnormalities, even subtle ones. Risk prediction seems to be one of the most important areas where AI technology can provide very useful assistance. For example, machine learning algorithms analyzing Medicare data were able to identify preoperative risk factors associated with negative outcomes and superutilization of medical expenditures postoperatively. Not surprisingly, a startup company raised many $millions to develop machine learning systems predicting which individuals are likely to require high-cost care. As for specific cardiac problems, machine learning deep neural network methodology has successfully predicted risk after the Norwood operation with excellent accuracy. If we go down to individual patient level, for clinicians managing sick patients under considerable time pressure, as we all are, AI was shown to predict over 90% of all acute kidney injuries requiring subsequent dialysis with a lead time of up to 48 hours. This would enable measures to prevent the need for dialysis. Another machine learning-based algorithm has served as a warning system for prediction of serious intraoperative hypotension. Unfortunately, for the technical part of the work of a surgeon, the promise of AI still remains largely a promise. Robotically assisted surgery has been available for some time, but it has been mostly useful for specialties other than cardiovascular surgery and certainly pediatric cardiac surgery. Still, there are some new, very ambitious AI-based surgical platforms in the works. The Verb surgical system is being developed jointly by Google and Johnson & Johnson. It is envisioned as a totally robotic platform with all robots interconnected via the internet, integrating VR data and deploying machine learning analysis of all patient information. Another important issue is accountability, especially for medical applications. An error committed by a physician may lead to major adverse consequences, but these are typically more limited to one or perhaps a few patients. In contrast, a faulty algorithm leading to erroneous recommendations, for example in drug therapy, may have very widespread adverse impact. It is clear that doctors, hospitals, and health systems remain accountable for decisions made based on machine predictions and recommendations. It is our accountability towards our patients which underlies our need for interpretability. We need to understand, to interpret appropriately machine-based recommendations. It should be noted along these lines that the inner workings of many machine learning algorithms, such as deep neural networks, are so complex that it may be nearly impossible to understand how their specific output or a specific prediction was made, even for AI experts. For this reason, such models are characterized as black boxes. And importantly, the AI Now Institute recommends that for any high-stakes matter, including healthcare, we should not rely on black box AI. We can be helped by it. The European Union General Data Protection Regulation, introduced a couple of years ago, requires companies to give users an explanation for decisions made by automated systems. In the US, the FDA is developing a regulatory framework for AI software, which can be labeled software as medical devices if they are intended to diagnose, treat, or prevent disease. Fortunately, there are AI and machine learning-based methodologies which are definitely not black box methods, but instead offer full intuitive interpretability of their output. For example, Dimitris Pertsimas and his team at MIT has developed a machine learning method known as optimal classification trees, and he has applied this to various medical settings. In one of these, he has used OCTs to develop highly accurate models for predicting risk in emergency surgery. Now, the workings of how the OCT algorithms reach recommendations are fully transparent to physicians, and therefore they can trust the machine recommendations. So what about possible specific applications of AI in congenital heart surgery? First, there are numerous possibilities leveraging the strengths of AI in image analysis. Imagine, for example, a pediatric cardiology, pediatric cardiac surgical conference discussing a complex patient. An appropriate AI system could have integrated all the available information from modalities including CT, MRI, echoes, angios, could have performed automatic segmentation of images and produced patient-specific 3D models, both virtual and automatically printed physical ones. These models could then be readily used for surgical decision-making, planning, and preoperative simulation. Also, intraoperative management could benefit by AI-based analysis and fine-tuning of anesthesia and perfusion parameters to optimize outcome, minimizing risk. The surgical procedure itself could also receive multimodality support in the form of machine learning-based integrated advanced imaging technologies as envisioned in the Google Verb surgical system I described earlier. Postoperative care could also benefit from AI-powered multi-parameter monitoring and analysis aiming for optimization of hemodynamics recommendations and for real-time adverse event prediction. I would love to see a system which would predict accurately and therefore help prevent certain very unpleasant events which probably most of us have regrettably faced. For example, the dreaded, otherwise unexplained sudden cardiac arrest in the pediatric cardiac ICU. Now, all these exciting applications are possible given data and effort, but they are still not available now. What are available now, however, are very powerful and very versatile machine learning-based tools for predicting risks in congenital heart surgery. For example, our multidisciplinary team effort bringing together the ECHSA congenital database and the data analytics team of MIT and Alexandria Health, led by Professor Dimitris Pertsimas, has developed highly accurate nonlinear risk models for predicting outcomes after congenital heart surgery. Importantly, the predictions of the models are fully transparent to the physicians and they are fully interpretable. Based on these models, which present themselves as decision trees, a user-friendly calculator for predicting risks of individual patients based on their preoperative profile was also developed. Our preliminary results in these efforts, which had been accepted for presentation at the AATS meeting last May, which was cancelled, are currently under independent review. To summarize, the promise of AI in medicine is enormous, ranging from achieving unprecedented diagnostic accuracy and efficiency to optimized decision-making and to provision of optimal treatment recommendations, even of specific therapy support. This promise can also be fully realized in our field of congenital heart surgery, and the potential benefits for our patients are huge. Still, achieving these goals will not be accomplished without major efforts. The challenges are great, but congenital heart surgeons have historically proven that they do not shy from effort, nor do they fear change. On the contrary, our history is built on bold innovation. Furthermore, our culture is that of multidisciplinary cooperation, and this particular frontier requires even closer cooperation of very different disciplines. It is important that we cooperate closely with our partners in the computer science world and to become actively engaged in these joint efforts. Artificial intelligence depends on the collection and availability of large amounts of high-quality data which are collected by us humans. We should make sincere efforts to cooperate, unifying valuable data scattered in various databases around the world, making them available for research. It is important to avoid infusing data with human biases and to avoid the pitfall of having machines learn from erroneous human practices of the past. We must understand the limitations of this exciting and powerful technology so that we can interpret its output intelligently. We should understand the need for and participate in the development of necessary and reasonable oversights. It is clear that computers are becoming unmatched experts at thousands of specific tasks, and that their assistance and support will definitely become ever more important in our practice. For the moment, it appears that computers are lagging behind in the so-called general intelligence and cannot be substitutes for physicians. The doctor-patient relationship will remain the cornerstone and guarantor of excellent care, which will undoubtedly be enriched by the deep insights of machine learning and further empowered by the remarkable achievements of AI. Clearly, the responsibility for our patients continues to be ours alone. Our practice is and will always continue to be guided by our Hippocratic oath. I would like to conclude with a favorite quote attributed to Albert Einstein. Life is like riding a bicycle. To keep your balance, you must keep going. I thank you very much for your attention.